Practical workshop number 4 therefore consists of aligning what we saw in workshop number 1, that is the elements of sono-anatomy, nerve recognition, including the structures and their dynamic characteristics. With ultrasound imaging and step number 3, the choice of the puncture site and visualization of the needle. So here, of course, this is workshop number 4. We will review the different limbs, the various blocks of the upper limb, the lower limb, and then the diffusion blocks. So let's start with the axillary block. So as you can see, I position myself like this. I take the patient's arm a little onto myself. My right hand is stable and fixed, slightly stabilized on the wrist so as not to move my image. And I start to scan and follow. Here we see a slight anatomical variation, but it more or less matches up. So to be a bit more didactic, we'll do it this way. So you see the main landmarks we saw earlier, namely the bone and the skin. The tendon of the latissimus dorsi, so as I was saying, to put things into perspective, the radial nerve, which is always located above at this level, and then the musculocutaneous nerve. Now you can see that the more characteristic image would be to have the musculocutaneous nerve between the biceps and the coracobrachialis. Well, this is part of anatomical variations. In a significant number of cases, as you can see, it gets closer to the median nerve. Once again, we can identify the elements from step 1, namely the musculocutaneous nerve, which is clearly visible right here, and the median nerve. The radial nerve, and then when we tilt the probe just a little and follow dynamically, we can clearly see the anisotropy. Anisotropy is a concept I forgot to mention to you earlier. In fact, during the dynamic tracking of the nerve retains its properties, keeps its nerve shape. This is precisely what distinguishes it from a fascia or a tendon. So workshop number 4, do it on a volunteer. And then you spend about 15 minutes on each nerve. And then you practice identifying the elements we've seen and memorized. You follow the nerve bundles dynamically to make sure they are the intended anatomical structures. There is no need for neurostimulation. You know, the median nerve is clearly visible in this position. And if we keep following it dynamically, it will curve around the artery. So that's it for the artery, and that concludes the procedure for the ultrasound-guided axillary brachial plexus block. We're going to take advantage of this position with the additions at the elbow. Now, this is very important and very interesting. I'm going to take my gel, simply because you keep the same position. You take the line of the elbow and you place your probe. So here, as you can see, it's the same as before. You need to reduce a little to focus and optimize your image. We can see the artery here with the median nerve. It's a bit like the image we had earlier. You see the artery and the median nerve. To focus a little, I have a new ultrasound machine. There you go, like this. And you can find the image of the artery accompanied by a median nerve. The puncture will be done in this direction. Now look here, I'm taking a slightly wider field, just a bit more. And I rotate 180 degrees. And I get back my image of the radial nerve that we saw in step 1 with the humerus. And then this little image shaped like this. And so I can do an additional injection at the elbow. Basically, when you start your axillary blocks, it's not very easy. You perform your block at the axillary level. And then if there's one of the structures you didn't see clearly, you keep the position and inject 3 to 4 cc. For the additional injection at the elbow, we'll take this opportunity to show you the last one, and all of this will really help you achieve 100% success at the beginning. So I told you about this big muscle here, the FCU, okay? So you position yourself a little bit at a good spot. 9 to 10 centimeters here, okay? And then you place your probe like this, and as you can see, we find exactly the same image as earlier. All right, you just need to enhance it with the ulnar nerve, which is at the top. So this is actually quite common. It's almost always the case. With this image, there are very few anatomical variations at this level, and it allows you to achieve a 100% success rate with your nerves. With your blocks, sorry. There you go. So here we clearly see the elements we looked at right at the beginning. So we'll move right along to the upper limb blocks, starting with the interscalene block. For the interscalene block, it's the same. It's quite simple. You start from the clavicle. So you place your probe against the clavicle and move upwards. Okay? All right, well here it's really, we're live, you see there it is. So we use the landmarks that we saw right at the beginning. The anterior scalene, okay? The middle scalene. Here we have the sternocleidomastoid. And so as you follow along a bit, you see here we have a slightly unusual configuration again with, there you go, C5 and C6, all right? So by narrowing the field, we'll get better resolution. There you go, C5, C6, we find the anterior scalene, the middle scalene, okay? I haven't talked to you about the superficial cervical block, but if you had to do it, here you can see the long thoracic nerve wandering a bit through the middle scalene, which explains why it's always important to inject within the field, because if you're out of the field, you could easily hit it. This structure, so if you had to perform a superficial cervical block, it is this specific layer of fascia located right here, into which you carefully administer an injection of a few cubic centimeters to effectively reach and anesthetize the clavicle area, a relatively small and specific portion of the labrum, and the acromioclavicular joint. If you want to perform a regional anesthesia procedure, a shoulder surgery under pure regional anesthesia. The supraclavicular block, so as I mentioned to you, you have the classic description, which I don't really like, with our first rib, the clavicle, and the pleura underneath, and then the artery. The problem quite often is the inferior trunk. And the inferior trunk, sometimes you see it has already crossed over. So I prefer this approach, which corresponds to a trunk approach, or the bispes, if you will, with the superior trunk here. As an observer, I'm very close to the screen, so maybe you can't see it, but it's the superior trunk, which would correspond to C5, C6, which would be the bis. The middle trunk, which would roughly correspond to C7, and here you can see it perfectly, that's it. That's your target, to be 100% effective. So there are several reasons. First, we push the artery a little further away. Then we're sure to get both the anterior and posterior components of the inferior trunk. And that's often what's missing. When you do the pocket corner, or when you use the classic supraclavicular approach, and then you have the superior trunk. Now, what's also important is that you can combine this block, for example, with a PEX. Why a PEX 2? Why a PEX? Simply because you can cover part of the intercostobrachial nerves. Well, these are actually fairly recent concepts. I won't dwell on that, but you can ask me in the comments or through the contact forms. What I meant by that is a bit complicated to explain to you right now. But for example, with this trunk level supraclavicular approach, here you can clearly see the anterior scalene, the middle scalene, the superior trunk, the middle trunk, and the inferior trunk. It allows you to perform all surgeries of the upper limb. And if you see that it affects the clavicle a little, you just add 3 cubic centimeters with the same puncture point. And then if you feel that you need to cover the inside of the axillary hollow and the intercostobrachial nerves, which is more of a thoracic component, right after that you can do a PEX. For PEX, you place your probe parallel to the clavicle, then you slide it, and you can see, well, here it is, you can see very clearly. You see the bony processes here. There's a small artery, which will be the axillary artery, and then you have the injection with the minor pectoralis and the major pectoralis. You can see the small arteries, so we have PEX 1, and then the 2 injections for PEX 1 and PEX 2. And then, if you go a little further into the axillary hollow, it starts with the beginning of the serratus. So these are diffusion blocks. We're not going to talk about them here, but these are blocks that are quite easy to identify, but their effectiveness really depends on the position of the injection site and the number of punctures. In your workshop, you can easily practice on a volunteer, spending 15 to 20 minutes on each block, the upper limb blocks, to help you learn to recognize all the structures. The interscalene block, the single nerve block at the elbow, the supraclavicular block, and then the PEX block. The same goes for the workshop. You can also practice the sciatic block on a volunteer. So for the sciatic block, using the subgluteal approach, you place the probe. Here, it's a bit on the external side. And you can see here that we have a perfect image of what we saw earlier with the appearance of the sciatic nerve. So there you go, we can position it very well. Actually, there's only, at the subgluteal level, it's not that far. Well, here, Sam is particularly slim and thin, but generally it's about 4 centimeters deep. So we have the characteristic image of the Sono-Anatomy element from step number 2. So just like we did with the nerves in the forearm, we can also very well do a workshop on this. And as you can see, we're following the nerve, right? And here we're going to follow the sciatic nerve along its path between the buttock and then the popliteal fossa. And so here you can see its appearance. You notice that it starts to split. So we find the somewhat traditional aspect of approaching the sciatic nerve via the popliteal root. So you see that here at this level you have the sciatic nerve dividing into 2, the artery and then the condyles. If you want to do an IPAC, I absolutely did not include this type of block in this version of the book, but the IPAC would be an injection under the artery, under the popliteal artery. It would be at this level along the condyles. So that's it for the sciatic block. You see, remember this image, the sciatic block via the subgluteal approach. So now we're going to turn around and do the femoral block and the BIPSI, the iliofascial block via the suprainguinal approach, and we'll finish with the table. So now we're going to move on to the practical workshop for the femoral nerve block. You see the position of the probe as always. My landmark on the outer side and my hand firmly stable on the patient. We've seen a little bit, we can identify the anatomical structures, and we can rock the probe a bit to see everything. My main landmark is therefore the femoral artery. You can see here, right next to it, the vein, which I kind of forgot to draw earlier, and right next to that, the femoral nerve here. So there you have it. This is one of the simplest blocks. This is something you can do at a somewhat beginner level, but of course, once you master the visualization, here you see a slightly better image. When you're steady and have the right view, don't hesitate to make small tilting or slight rotational movements to optimize it. And then bring your puncture point a bit closer, just like we saw by translating your hand. My puncture point comes in from here, so my probe comes in from here, and my target is the femoral nerve. I'm taking advantage of this position to show you the iliac fascia block via the suprainguinal approach. Your main landmarks will be the anterior superior iliac spine, the pubic symphysis, and then at the outer third, it's often a little bit. So here I've passed. Oops, now I have too much. All right, there we go now. And as you can clearly see, your landmarks are positioned right here. So this perfectly aligns with the anatomical diagram we discussed earlier. I currently have a bit too much gain in the depth, so you can manually adjust these settings there, though maybe that is not quite enough. I really hope you can see everything quite clearly on the screen. There, I will add just a bit more depth to the image. There we go, that looks much better now. To show you. So my main landmark is the circumflex artery. Now, in his case, in Sam's case, we can see it very, very clearly. And then we have the large iliac muscle coming in, so that's really the typical description. And then the anterior superior iliac spine. So you come in from here, and I recommend injecting a little bit below the fascia in order to make the circumflex artery rise, and you'll have the product spreading up to the femoral nerves. So let me remind you that the suprainguinal approach to the iliofascial block is an exceptional block for all lower limb surgeries, especially knee surgery and femoral neck surgery, and all of that. And it covers the 3 blocks, the 3 nerves, so it's the famous 3-in-1 Winnie, but adapted for ultrasound guidance. And your main landmark is the artery, cycloconflex artery. So it covers the femoral nerve, right? The nerve. Obturator nerve and the lateral cutaneous nerve of the thigh. So get familiar with this block. It's one of the most promising blocks and currently provides the most benefit. So we're going to cover the last 2 blocks. We'll get set up again a bit for the tap block and the paravertebral block. And with that, we'll have finished this workshop covering the 9 blocks. The main ones, namely the 3 blocks for the upper limb, the 3 blocks for the lower limb, and 3 diffusion blocks, which allow you to perform about 95% of your practice in anesthesia. Regional anesthesia. So the tap block, so that's one of the blocks that is both the easiest to identify because the Sono-Anatomy is really very simple and well known, and to achieve maximum clinical effectiveness, which in my opinion is actually quite complicated, because the effectiveness of your block really depends on where you position your probe. So the classic description is this: you place the probe here like this, and then you get the image. Move it a little bit. Now this is characteristic. You have the three layers, the intestines moving here, the transversus, the internal oblique, and the external oblique. So a tap block is that. Afterwards, your effectiveness will depend on where you position your probe. A little tip, sometimes in slightly overweight patients or those with a fatty pad, counting the layers can be a bit difficult. I recommend starting from the inside with the intestines. The intestines are easy to recognize because they move. And then you'll know that your tap block is the second to last layer. So you can even see here, with the device's resolution, the small branches that are between the internal oblique and the transversus abdominis. So your target for diffusion is here. So start from the inside and don't go 1, 2, 3, but rather go 3, 2, 1, and then your diffusion site will be between the second to last structure. This sometimes helps avoid confusing it with a layer of fat. The last block we're going to look at, and that you need to practice, is a slightly more complicated block, really reserved for experts, or at least it has a somewhat longer learning curve. You really need to master the easy blocks first. Axillary blocks, femoral block, sciatic block. After that, move on to a higher level to more advanced blocks. A bit more intermediate, like the PEX blocks, the supraclavicular block, which isn't that easy, the iliofascial block via the suprainguinal approach, which can be classified as an intermediate block before tackling the paravertebral blocks. Quite simply because the angulation is greater. You are very close to the intervertebral foramina and also to the pleura. But it's a block that is extremely effective with an efficacy as significant as an epidural. Whether it's for thoracic procedures using paravertebral blocks or for colonic and digestive surgery with paravertebral blocks, either unilateral or bilateral. A little bit lower down. So we're going to position ourselves. Actually, I position myself as if I were doing an epidural. I do it with the patient sitting because I am more comfortable, but you can absolutely do them with the patient lying on their side in the lateral decubitus position. Personally, I'm more comfortable with the patient sitting. Generally, I do them on an awake patient to go faster. And above all, to have a better view of my needle and the area where I'm going to operate. So let's get set up. And then we'll show you this last block. Here it is, the last block in this series from the practical workshop, step number 4, the paravertebral block with its variation, the erector spinae block. So as I told you, I do it with the patient sitting, okay? And then so we move a little like this, and then we find the image. There you go. So here we have exactly the transverse processes. And you see, as I move a little, the pleura is here. And so the injection site for a paravertebral block is at this level. It's this little triangle under the ligament, okay? Intercostal transverse. I can't quite remember exactly what it's called. It's this one, and that's the injection site. It's there, and you should see your pleura collapsing, so your needle. You can approach it from here, or you can angle it a bit like this, so you're less bothered by the transverse processes. And as you can see, we find the same outline as at the beginning with the two bony processes. And then the muscles, which are between the two bony landmarks, and can have different names depending on the level you're at. Strictly speaking, it's mainly this aspect of sono-anatomy that's important, and the injection site. So you see like this. Now a small clarification. This is the paravertebral block. At this level, it's the mid block. And here you have an erector spinae block in contact with the apophysis. So this is really the most effective. But sometimes it's a slightly tricky block, a bit deeper. We're getting close to structures, but it covers the entire surgery. Thoracoabdominal surgery, the ESP block, the erector block. Spinae is a very good block, for example, in cases of trauma to the wall, or for instance, for acute lumbago. And with all that, you reach only the bone and you inject the paravertebral at this level. It's still the most effective block, but it requires a bit more expertise. And here you have roughly the visualization. Again, this raises questions about the level of punctures, the number of punctures, single or double punctures, unilateral or bilateral punctures. It depends a bit on your surgery, but here I refer you to all the more comprehensive manuals or websites that discuss this. They explain it much better than I do. There you go, we finished with this workshop.